will be joining us shortly. Good morning, colleagues. Vivian, can you confirm that you can hear me?
Hi, Tian, I can hear you. Anban has joined.
Great. Thank you, everyone. Colleagues, COVID-19 conversations are brought to you by the African Alliance with support from the South African Medical Research Council and the Department of Science and Innovation and the Vaccine Advocacy Resource Group, which is 100% funded by activists. We bring you these calls in partnership with the Community Constituency COVID-19 Front, the Treatment Action Campaign, and APHA. Thank you for joining us. These calls take place every Thursday at 10 a.m. and seek to bridge the divide between civil society and those who hold power and platform in the COVID-19 space. All of our recordings, along with the transcript of the Q&A sessions, can be found at africanalliance.org.za. We encourage pre-submitted questions and welcome questions or comments in the chat box during the call, and we will do our best to answer all of them. Those we do not get to, we will reach out to our guest after the call to secure those answers, and those will be included in the transcript. So welcome, colleagues. Today we speak to Dr. Anban Pillay, the Deputy Director General of South Africa's National Department of Health, hailing from KwaZulu-Natal Province. A former health intern, Dr. Pillay was spurred into a life of public service when he witnessed the substandard care offered to communities in Chatsworth in Durban during apartheid. Pillay studied pharmacy at the University of KwaZulu-Natal and obtained his medical degree at the same institution. He later completed a PhD in health economics in Australia. An early champion of the national health insurance, he works to ensure that staffing, equipment, and access to medication for the public sector remain on the agenda, as does the urgency to standardize healthcare across provinces. Dr. Pillay serves on the Ministerial Advisory Council on COVID-19. Dr. Pillay, thank you for taking the time to speak with us and welcome. Our partners at the Community Constituency COVID-19 Front hosted an engagement session with Minister Mkhize last night that created a lot of dialogue and generated significant interest. There's clearly a hunger for information on the status of government's leadership in the COVID-19 response, with a very clear interest in getting vaccines on the ground and into people's arms. So in that vein, I will ask you to share with us a 20-minute overview of the work that your department is leading on the COVID-19 front, and in particular, your role in ensuring that South Africans are able to access a COVID-19 vaccine in the near future. Dr. Pillay, thank you for joining us and welcome, and I will hand over to you.
Good morning, Tian, and good morning to all the colleagues that have joined the call. It's a great pleasure to participate in this session. We often, in these media events where we don't necessarily reach people on the ground as we are now, and I'm very glad that we're having this conversation, because I think you have an opportunity, and I have an opportunity to hear from you as you do from me. So I don't know whether you'd like me to just speak or to do a presentation specifically, Tian, which would you prefer?
So whatever you're comfortable with, we can do either.
Okay, I think if I did a presentation, I'll probably take too long, and I think I must give time for questions. So I'll just make some brief points, just to stick within the timelines. I think it's important to say that we view vaccines as a critical component in the response to COVID. We are aware, nevertheless, that vaccines need to be used together with the other interventions in the response to COVID at this stage. The minister appointed a ministerial advisory committee, and their role is largely to look at the scientific evidence, to look at the vaccine options based on that evidence, and advise us on which will be the most appropriate procurement approaches that we should be taking. Looking at the priority groups, who should be vaccinated first, second, and what is the basis for doing that, and also advise us on the strategy for the vaccine rollout, and provide advice as well where appropriate about opportunities for us to manufacture or develop a vaccine. The committee is largely based on people that are involved in the vaccine world, chaired by Professor Shub. Includes people from the University of Cape Town, Professor Hassi, Professor Mpashlele, Professor Helen Rees, an ethicist, Professor Dai, as well as the chairs from the other MACs and representatives from Treasury and Science and Technology, and as well as SAPRA. So there's quite a broad group of people that are involved in the vaccine work. In addition to that, there is also a group that's looking at financing of the vaccines, and that involves our National Treasury ourselves, as well as big business, which has come together to say we'd like to lend a hand financially and otherwise to make sure that this is something that can be rolled out in the shortest period of time. And so we have a group that's working on that. I think it's important to say that our approach around vaccines is firstly to provide individual protection to persons, or personal protection. And at a second level, we're looking at herd immunity, and that requires us to be as broad as possible in terms of our program and vaccinating as many people as is reasonably possible, taking into account what would be the limitations of achieving herd immunity. We have divided our program into phases, a phase 1, a phase 2, and a phase 3. Phase 1 is largely linked to healthcare workers on the health platform, and we'll start with that now in February, once we get our first doses from the Serum Institute. And after moving through the healthcare workers, our next phase is essential workers, those working in congregate settings, older persons, that is those people over 60, and then looking at persons that are 18 years and older. This is the list the committee had come up with. I know there are a number of representations that have been made to revise some of the groups or include specific groups within these categories. I think that's a process that the committee is continuing to go through. I think we should see this as a dynamic process, because clearly the committee would not have all of the information to be exhaustive. The third phase is basically all other persons over the age of 18 that could potentially be vaccinated, and opening that up to basically everyone. The intention of the program is that it's free at the point of care, so you should not be discriminated against whether you can pay for it or not. Medical schemes will clearly pay for their members, and that would happen through a back office function. So that's independent of what anybody would be needing to pay at the point of care, which will be free. We would also be contracting with private providers to augment our vaccine program. As you know, our vaccine program at this stage is largely centered around the EPI program, and we do around 15 to 20 million vaccines a year. Here we're talking about a much larger program, 2 to 3 times more than what we had in the EPI program, and so we're going to have to bring on many more people. So we've brought on board private pharmacies, as well as general practitioners, as well as the occupational health and safety service providers within the employer groups, so that we can expand our platform around delivery of vaccine service. I think on the vaccine dose supply, I think it's important to appreciate that the global supply in the first phase, that's January through to March, is fairly constrained, simply because most companies are still ramping up in terms of their production to meet demands for global requirements for the vaccine. And so in phase 2, much more vaccine will become available. And I think by phase 3, the production would have stabilized, and demand and supply would have been equivalent as such. So we have then aligned our rollout in line with that supply. So phase 1 is the healthcare workers, and by the time we get to the phase 2 group, we also anticipate that we will be in quarter 2 when much more vaccines will become available in terms of supply. Our intention is to have multiple platforms by which we can deliver vaccines. So that's the workplace-based vaccine programs, both at district hospital level, as well as private hospitals where they would be also doing vaccination programs, outreach work-based vaccine programs, and mobile teams going from facility to facility, especially in our more rural areas where clinics and it would be impossible for the staff to then go around to a particular center given the distances. And then thirdly, we would also be bringing on board, as I mentioned, private pharmacies and GPs who would be able to deliver the service. The intention is to establish an IT system which should be the backbone of how this is delivered, and we would be setting up an IT platform which is largely going to be app-based. You would register on the system and indicate where it is that you would prefer to have your vaccination done. You'll make some sort of an appointment around date and time, and so the vaccine delivery will be aligned to the number of people that will be coming to that facility on a particular day. The reason we're doing this is that these vaccines are temperature sensitive, they're light sensitive, etc. And given that they are in limited supply, there is a challenge that they may well expire if we just simply distributed them across the country without an appreciation of where the need is. In terms of our selection of the vaccines, our big issue is availability. So we first try and identify vaccines that are available. The second question is, and if it's available, is it effective? Is it safe? And is it of good quality? And here SAHPRA comes in terms of what they would advise us in terms of those parameters. And if those two parameters are then satisfied, the other factors are clearly, the ease of use. Some vaccines need to be reconstituted. Some are fine. Some have to be stored at -70, for example. Those pose particular storage and distribution challenges. Then there are cost issues as well, but those are not the topmost issues. The most important issue is clearly availability, safety, and efficacy, as well as the ease of administration. SAHPRA has taken a very agile response to the regulatory approach. They have got into a number of agreements with regulators across the world through the reliance mechanism. So there's a lot of sharing of data. So when a vaccine becomes available here, they will review the vaccine in the context of what other regulators have done. So they've done this with the vaccine from Serum. They had a number of meetings with them. They have now gone through a process where they will issue what's referred to as an emergency use authorization. And I think by the end of the week, that would be finalized. And in that process, they clearly will provide an assurance around the safety, quality, and efficacy of the vaccine. However, there is a stringent pharmacovigilance program that has to be linked to this, given that there are aspects of the vaccine that we need to learn a lot more about, and a pharmacovigilance program is critical for us to be able to do that. In terms of procurement, we need to respond quickly to the procurement issues, and devolving this to provincial level and going through tender processes has a number of challenges linked to it. So we have established a committee with the National Treasury and the Chief Procurement Officer, and we then are able to address procurement opportunities immediately to make sure we comply with our legislative approach and make sure that we have value for money, as well as making sure that everything's accounted for in terms of the best use of our funds. Security is an important area as well, particularly from a safety point of view, because we've heard of vaccines disappearing, etc. And so there'll be some track and trace measures that are going to be put in place in order for us to do that. So the data system that we're putting in place will, have information about the patient, the establishment, which vaccine, the safety information, etc. And that system is on track to be implemented when we start our health worker program. And so we will have a full database and we'll be able to report about how many people have been vaccinated where. I know there's been a lot of this attention in the media. So let me say we've been in discussions with Pfizer, AstraZeneca, Johnson & Johnson, Moderna, as well as the vaccine manufacturers in China, Sinopharm, Sinovac, as well as the Russian vaccine, Sputnik 5, and the other manufacturer in India as well, the Bharat Biotech. So all of them have given us feedback on the availability, etc. The big challenge, which I mentioned earlier, is that most of them are either in trials, phase 3 trials, where they're not able to share that, and our regulator clearly has to confirm the safety and quality. Or the other problem that exists is they don't have sufficient supply in Q1, but are certainly able to help in Q2 and Q3. And so I think if I was to summarize our supply issue, I would say in a nutshell, we probably are about 80% there in terms of our supply. Remember, COVAX is going to supply us about 12 million doses, and the minister announced 9 million doses from Johnson & Johnson. We additionally just finalizing our agreement with Pfizer. So I think we're about 80% there in terms of our volumes. And by the next few weeks, we should have closed that up after our discussions with our colleagues in Treasury to finalize the procurement issues. I'll stop there. Thank you very much, Tian, for the opportunity. I tried to stick within my 20 minutes, so at least we can have more time for questions.
Thank you. Yeah, I mean, it's certainly a common theme, I think, throughout this pandemic has just been the overwhelming amount of information and the amount of layers and nuance that is very often lost in a media headline. Some of the discussions we've certainly been having with SAPRA over the last few weeks was the very real urgency to begin building a broad base of South African support and knowledge of the work that SAPRA does, and moving almost from the shadows as a regulator that does its work behind the scenes and really bringing it into public view, to really work against the sentiment of anti-vaccination, to remind South Africans continuously that we do have this body. We have a world-class body with world-class scientists that ensure that whatever vaccine is going to materialize on the ground, it's safe, it works, and it's of high quality. But speaking about that, I think at the top of most people's minds is this 1.5 million vaccines, or the 750,000 doses that are coming from the Serum Institute shortly. Could you just speak quickly to what vaccine is that? And what are your initial, you touched on healthcare personnel. So could you describe that vaccine? What vaccine is coming first as part of phase 1?
Thanks, Tian. So the first vaccine that's coming through is a vaccine that is produced by, that was initially produced by AstraZeneca. So maybe just to explain all of the intricacies around. AstraZeneca developed the vaccine together with the Oxford group. And after the development of the vaccine and the success of the clinical trial, the decision was taken by AstraZeneca that they would like this vaccine to be available globally without a constraint of production. So that meant that AstraZeneca would have to spread its production far more widely than what it had been doing, in terms of other vaccines. Signed up a number of producers globally, and then divided the global market so that producers focused on supplying particular markets. We've been given 2 suppliers, or 2 producers, if that's a better way of putting it, for the AstraZeneca vaccine, one of which is the Serum Institute. So that's how we ended up with them, because they've been allocated our market for the vaccine. The vaccine has been registered with the MHRA in the United Kingdom. The process of production of the vaccine at the Serum Institute has to comply with the production quality requirements of the innovator of AstraZeneca. So AstraZeneca is monitoring the production. So even though they have in simple terms outsourced their production, they are monitoring the quality of the product all the time, because effectively it's their brand in effect. And so in all our discussions with the Serum, AstraZeneca has been very much part of it to make sure that the quality issues of the product are guaranteed. And they've been very, very interested in making sure that that happens. So we take a lot of comfort in their interest in that, and I think that will certainly help us in also assessing the quality of the product. When the product gets here, I should say we have in South Africa a national control lab. So the lab will still take samples and do testing to confirm the quality of the product. So in case there were any deviations in temperature, etc., during transport, and it affects the quality, the lab wants to make sure that the product is still stable and of good quality before we distributing it to our facilities. I hope that clarifies that. Yeah.
Thanks for that. I think Oliver's also raising an important point, but I wanted to give some context. You know, at the outset of the pandemic, we had the CEO of Pfizer, Albert Bourla, who basically said the notion of vaccine developers foregoing profits on COVID vaccines is fanatic and radical. Then, with AstraZeneca in June, they made a public statement that they would provide doses of its vaccine at cost price until the pandemic ends. In October, we found out through a leaked memo that AstraZeneca then said that they will determine when the pandemic is over, and therefore they will determine when cost price happens or not. So quite interesting, but it speaks directly to the point that Oliver is raising. We're seeing a report this morning in Business Day that South Africa is paying double the rate for vaccines from Serum Institute. What happened to the at cost and no profit commitments from Oxford and AstraZeneca?
So we also, when we were presented with those costs, were quite taken aback, because we also saw the $3 costs and below $3 in some cases from the leaked procurement prices that came out of Europe, which were even higher than the COVAX prices that we were given. And when we inquired from both the Serum Institute as well as from COVAX around, from AstraZeneca around that, we were told that, look, there is a tiered pricing approach, and that South Africa is a higher middle income country. And in terms of their formula, this is then the price that we would need to pay. I was also informed that the lower prices that are in Europe, which didn't add up, because if we were paying this price, then why was Europe paying a lower price? I was advised that the Europeans had funded the front end R&D, and so they were given a discounted price for the R&D. We don't know how much the R&D was and what the discount was, and we were just told from both parties that this is a consistent price that we would be charging all upper middle income countries.
Yeah. And it's very interesting hearing you speak about how Europe had said, they had made this investment into the R&D, et cetera. It makes me think about questions that we've been fielding since June, where we said, but hang on, we are playing such a key role in research and development. We've got some of this country's premier universities, research institutes. You've got contributions being made from government bodies like the MRC. So you, in essence, have South African taxpayer dollars funding R&D. You have South African universities rolling it out. You have South African bodies being relied on to prove efficacy of a product. At what point did we stand up and say, as much as Europe is demanding a discount, did we at all, and perhaps this has been done, and so it would be great if you could share that, was there a point where we stood up and said, these are our bodies, our universities, our taxpayer money, and to be fair, our contributions have been fairly minimal in comparison to the global funding of these trials, even in South Africa. So I think there's a hunger at national level of trying to understand, when did our government stand up and fight for us? And of course, there's a huge amount of work going on behind the scenes. But perhaps now you could articulate the work that was done, if any, to really motivate for similar discounts that Europe is getting on the basis of our own local investment into R&D of these vaccines?
Yeah, I think in the case of the AstraZeneca vaccine, we were left to negotiate with the party that didn't do the R&D here, and we were not very successful in negotiating a lower price in terms of the serum vaccine. It was basically this is our price to upper middle income countries, and you can decide to take it, or if you don't want it, well, we're open to sell it to somebody else. But I think the other companies have been more responsive. Pfizer has certainly been more responsive, particularly given that their trials were done here. And Johnson & Johnson has also been more responsive, certainly, around that. So I think we're getting different responses from different companies that we've engaged with around the issue of price. What we didn't want to do, though, is push the price debate to the extent where we don't have access, because given that demand exceeds supply, and the supply, it's currently a supplier's game, if I can put it like that. We don't want a situation where we simply drive price hard and we put at the bottom of the list for access simply because we have a lowest price. Because in the general medicines market, that's what happens when a company has a low price and margin. They first service the markets that are the higher price and margin, and then come to the lower price countries. And we didn't want to negotiate to that extent.
Thanks for that, Anban. Uteka from SANAC, who leads the implementation of the NSP, is asking, with the first phase of rollout for healthcare workers, will we cover HIV and TB healthcare workers funded by implementing partners such as PEPFAR and Global Fund, as well as healthcare workers in NGOs?
My understanding of the definition of healthcare workers is everybody involved with the healthcare delivery in terms of contact with patients. And I mean, the fact that they're funded by a separate party doesn't change the risk that they are presented with on a daily basis in the delivery of care.
Thank you. And I certainly know some of the work that the work streams are doing are certainly spending a lot of time unpacking this whole definition of healthcare workers, and it's really quite comprehensive. Are we receiving vaccines from the African Union?
Well, we're not receiving vaccines. We're part of the African Union vaccine procurement approach, which the president announced. As part of that, each country will receive an allocation of vaccines as part of that procurement. But our procurement will happen directly with those companies after we receive our allocation as such. So the AU is about a pooled procurement mechanism, I suppose is the best way to describe it. And also not to in any way have a discrimination between countries, because South Africa's buying power, I think, will certainly be higher than many other countries on the continent. So we could potentially outpurchase our neighbors in terms of procurement, but that's not the right thing to do. I think while we're complaining about what's happening in Europe and the US and other places where they've bought, 4 times the vaccines that they actually require, we also don't want to be now in that position where we purchase vaccine and our neighbors are left with nothing on the continent. So I think this is pooled procurement talks to the solidarity and fairness for access to vaccines across the continent.
Thanks for that, Anban. Anban, another common feature of the discourse among civil society and certainly researchers and some parts of government has constantly been this issue of the non-disclosure agreements. At what point do we arrive in a place where accountability to citizens is not negated by the existence of these NDAs, which to all intents and purposes have shut down transparency? And it's quite ironic because at the beginning of the epidemic, I know certainly many of us who have traditionally worked in the HIV and GBV space were just stunned at the levels of transparency. We kicked off with that huge press conference that essentially turned scientists into, almost rock stars. Everyone knew the names of our scientists. Everyone was excited about scientists. So we went from that level of transparency and engagement to this almost overwhelming brick wall of can't say anything, there's NDAs. What do you think is that comfortable space or that balance that we need to reach between government being accountable to its citizens whilst respecting necessarily, I would imagine, in the business space, these non-disclosure agreements?
My understanding about non-disclosure agreements is that they are largely linked to the process of the negotiation between us and the companies. As soon as the deal is concluded, our local legislation then, or the PFMA more particularly, kicks in terms of accountability. And I think there are high levels of transparency in terms of that. So we would certainly need to share the necessary information in terms of that. In fact, South Africa is probably one of the key countries that drove the transparency around access to medicines at the WHO resolution to create transparency around pricing and access. So we very much still there, and we'd like to share that. But I think at this stage we just need to appreciate that we're dealing with parties that that have control over the vaccines. And I think once we're able to procure them, we will certainly be sharing a lot more information, because we would no longer be tied down by the negotiation process as such.
You know, one of the things that stood out to me in one of the past African Union calls was when Strive Masiwa, we were discussing the pricing and availability of resources. And Strive Masiwa, who's one of the members who are leading the financing mechanism, kept on reaffirming that money in Africa is not an issue. All we want is these manufacturers to tell us how much their product is, and we will buy it for our people. So that just really stood out to me as quite a courageous and certainly interesting space. And I guess, you know, as a billionaire, I guess, you know, as a billionaire, you have certain freedoms and courage to say certain things. So it really struck me. But I think it speaks in a way to communications and how are we communicating all of this. Nombasa in the group is basically speaking about comms. We've been advocating as part of this multi-sectoral communication strategy we're developing for leaders, starting with the president, director and deputy director level like yourself, to be vaccinated publicly at the outset, and recognizing the power of seeing political leadership and civil service leadership being vaccinated publicly as a way to assist those of us in communities in our work to fight anti-vaxxer sentiment and vaccine hesitancy. Would you champion the initial vaccination of political and civil servant leadership at the outset as part of phase one?
Yeah, look, the Ministerial Advisory Committee was debating that. There are I suppose two views on it. The one view is very clearly the one you've articulated, where I think political leaders need to come out and be vaccinated so that the public has confidence in the vaccination program and the vaccines in terms of their safety and efficacy. The other side is that it may be seen that political leaders are getting protection before other people. So I think trying to just get that right is probably the issue. The MAC, I know, is looking at it, and I think they will probably provide advice to the minister on how when and how they should be vaccinated. But I think the point is very relevant. A number of countries have already seen the heads or the queens, etc., being vaccinated. And that's probably something that needs to happen here publicly, certainly. Yeah.
Are you eager to get vaccinated?
Yeah, I'd like to be vaccinated, but I also appreciate the argument that there are other people at higher risk than me. So I'm prepared to stand in the line and be told when is my turn, if I can put it like that. Yeah.
Oliver's asking, the first batch of vaccines are due in less than 2 weeks for phase one. Are we on par for rollout? Are we ready? When can we expect the first jab to take place? Day, month, date?
So we're waiting for Serum to tell us what day the vaccines will land in country. They haven't given us that exact date. They just said it will definitely be next week. I can just give you the kind of processes from there. The vaccine will have to be stored at a local facility for until the batch testing happens. So the SAPRA and the National Control Laboratory will take random samples and do testing on those samples and confirm that the product is still of appropriate quality. Once they've done that, which probably takes about 3 days, once they've got the results of that, they will then say to us the product is good to go. We have, in the meanwhile, been meeting with the provinces as well as the private health sector, and have a list of healthcare workers that need to be vaccinated in terms of the list. So we've tried to bring together the independent practitioners as well, who don't have a formal employer as such. And that coordinating committee will divide those doses between those two sectors. The stock will then go to either provincial depots or to a private depot where it will be stored. And using what is best described as a hub and spoke model, the doses will be distributed across that region. At a provincial level, the private sector will be working together with the provincial health department to make sure that there is coordination in terms of the vaccines delivery, as well as the individuals that are being vaccinated as well. We've worked very closely with the medical schemes that are on this as well, to make sure that there is very good coordination on numbers. So the intention is that all of the information of the people to be vaccinated will be uploaded onto the system before they get vaccinated. They will then effectively receive messages about the day that the vaccinator will be coming to their hospital or clinic or whatever, and to be ready to be vaccinated. And they will receive a certificate or a vaccination card to confirm that they have been vaccinated. Clearly, it's a 2-dose vaccine, so they'll be given a date for the second dose as well, and they would need to come back and get that.
Yeah, thanks. I mean, in the last few days, we've seen reports of at least 6 UK-based hospitals who have had to dump vaccines because people are not coming back for the second dose. And it really just reminded me of our never-ending conversation and challenge in this country around adherence and coming back to clinics. And what is the security situation in terms of these vaccines? You know, a lot of us on this call work in the GBV space. And so with the rates of violence, of crime, of murder, of mayhem in our communities, are we taking law enforcement out of communities to protect the vaccine? And if not, who is protecting the vaccine, which, as Interpol has warned us months ago, is prime targets for international and local crime syndicates?
So the vaccines have a particular coding on them, so we would know if there's a counterfeit in the system, because there is a code on each one, and the vaccinator is having to upload that code onto the system. So then we know which batch, etc. If there's an adverse event, amongst other things, we're monitoring it from that perspective as well. But in terms of the security, we've brought on board private security to manage the vaccines together with we've spoken to our military as well about securing the more larger vaccine stocks and where they'll be, given that we do stand that risk that vaccines will be stolen and moved to other places. Yeah.
What are we doing to ensure people come back for that second dose?
So the IT system has within it that, so if Anban Pillay went in for his vaccine today, it will then calculate the date by when he must come back. It will send him a message to say this is the date. And then closer to that date, there will then be a reminder to say this is the date you need to come back. We plan to then have if an individual doesn't respond to confirm which day they're coming in to get their vaccine at that particular facility, second dose, there will then be a follow-up with that individual to say, hey, you need to come back for your second dose. What happened? Are you okay, or is there a problem, etc., to understand why the individual is not coming back.
What are we doing about data? How reliant is this IT system on individuals' access to data? We know we live in a country with some of the highest data costs in the world. What does the access to data and the cost of data mean? Does the IT system you've described not have any data requirements? Does it require a smartphone? Could you just touch on accessibility and how realistic perhaps this IT system is in the context of data?
So I mean, I'm not a IT expert, but from what I've been told, the requirements for the system from a individual user perspective is it uses 1/3 of the data required that you would on a WhatsApp call. So I'm not sure how that stands up, but I was told it's very low. There is also going to be the opportunity, clearly, because not everybody would have a smartphone, to be able to register at the facility for when you would be able to come in and get your vaccine as well. Because clearly, we can't just have a situation where people who only have smartphones are able to register.
Mhm. We are told that health officials filed an application to SAPRA seeking emergency approval for AstraZeneca authorization just last week. Could this be a delayed process in the rollout for phase one? I'm not sure if this would be, could this be a delaying tactic? Could this delay the rollout of phase one, this application that health officials filed with SAPRA?
No, there's no delay. Remember that the Serum Institute had been talking to SAPRA from about December, sharing a lot of their data. And as their data became available, they were sharing that with SAPRA. They were waiting for two things in particular. The first that Serum needed was the approval from a stringent regulator on the clinical approval of the product, and that happened through the MHRA. The second was the Serum Institute needed approval from its local regulator, which is the Indian equivalent of SAPRA, called the DCGI. And once those two were in place, then Serum was in a position to then file with SAPRA. So the filing actively put in the documents to SAPRA for review. I'm very confident by the end of this week, we will get sign off from SAPRA for the importation of the product.
Thank you for that. One of the last questions, how are we dealing with or are there plans afoot to address this, what feels like a tsunami of stigma that is coming towards our health care facilities? So like never before, we've seen clinics that we've really relied on as community groups as key spaces for mobilization, for access to commodities, et cetera, we're seeing a level of stigma at these facilities, and they're almost being regarded as, I would rather not go and get my chronic medication from that clinic because that's where people's COVID go. So how are we dealing with perception and infection control at site, et cetera, in general, the stigma of healthcare facilities in the next few months or as we move ahead in the context of COVID?
No, that's an important issue, and it's a difficult issue for us. There are even people that are infected with COVID that would say to us, "I'm not going into the facility because I'm scared about infection." And but they already have COVID, but they were so scared to go in, and they needed the oxygen. So this fear stigma is very difficult. We're trying to put out messaging through social media and other media to try and explain to people that it's more important for you to take your chronic medication because you're basically increasing your risk exponentially with poor control of those chronic conditions. So if you were to get COVID, it'll be far worse if you didn't have control over those conditions. So we're hoping that those messages get through in our facilities as well. We're trying to, I think as our vaccine program continues, there would be a sense of safer environment, I would anticipate or hope, and people will be coming back. But certainly our colleagues that are running the different programs are engaging with the provincial colleagues around trying to encourage people to come back post this vaccination program, because I think there will be some perceptions about the safety of our facilities after that.
Yeah. Thank you for that. One of the provinces in this country, the Eastern Cape, that has historically just been really a heartbreaking and tragic story relentlessly in terms of the quality of the public healthcare service. Just in one period during the pandemic, lost the equivalent of 90,000 Pfizer vaccines to corruption. What would your comment be to us as people working in communities? How do we begin to have a discussion in communities around limited resources, and that's why we can only do vaccinations in terms of phase 1 or phase 2, for example, in the context when, like I say, up to 90,000 vaccines are being looted in terms of money and corruption in one province in one period? What is the Department of Health doing in terms of contributing towards aggressively tackling corruption in the public health system?
I think corruption in the public health system is, much broader than just the health system. But the health system, I think, is an attractive terrain for this, because it has all of the elements that would allow for easy corruption. It's more difficult to do it in a department where they don't have the extent of the resources that we need to supply. We supply food, beds, medicines, everything. So I think in that context, we certainly are trying to work with the SIU. There is a committee that's in place that's trying to identify the area of them. We certainly send those through. In this process of the vaccines, you would note that we are doing the procurement centrally. When procurement is done centrally, and I've been involved in this for over 2 decades now, we've never had a single case of corruption or anything, because it's much easier to have a focus on a single group of people, and so the opportunity for that kind of thing is far more limited. And if it ever occurred, you can intervene more precisely, because it can't be a diffuse response as such. So I do think that those are some of the solutions in the short term. In the long term, I think that one of the big problems that we have in the health system, particularly, is around the information systems that are available. Much of the goods or services that are required to be delivered are not captured in an information system. So if Anban Pillay went in for a service, and if it's not clear what services and goods were delivered to him or her, it's easy for those products to then find their way out of the system as such. But if you had a system that gets into that level of detail, then there's clear accountability. That's why in the private sector, it's more difficult to do these things, because you have to have an account for each patient. And so the information system that we were building around, or are building around the NHI, is largely going to get to that level of detail. So you would have to account for what you did with the medicine, or how long you spent with the patient, etc., because the data will talk for itself as such.
Yeah. No, thanks for that. We're about to approach 10 minutes to the hour. Anban, we've been through for nearly a year now an endless stream of death, of despair, of sickness, of communities who have had to find new ways of survival against all odds, the traditionally weak social security system that is not meeting people at their point of need, existing and long-term health issues, our other pandemics that have never gone away, HIV and TB, etc. Amidst all of this, what gives you the most hope looking forward?
I think we've been through, so many crises. HIV in particular is the one that I think that all of us went through at some other point. I remember working in hospitals where there were more people that were dying than were living, and you had to reflect as what is the point of you working in a healthcare sector if you're only there to watch people die rather than having to save them. So I think the belief that we will be able to get over this, identify the interventions that are going to be able to save lives is critical, and work very hard at implementing that across the country, particularly to those who have the least access and are able to stand up and be first in the queue often to get access to care, but rather identifying those people and making sure they get access to service. I mean, today, if I walk into the same wards that I was working in at the time, I mean, I would be have difficulty finding a single HIV patient in those wards like the way I did. I remember over 2 decades ago. Yeah.
I think that's such a powerful message and a reference point to go forward. Colleagues, Dr. Anban Pillay is the Deputy Director General of South Africa's National Health Department. Next week, we speak to Ms. Nogoduka, who has been with SANAC Trust as the Executive Manager for the National Strategic Plan implementation since April 2019. She has also been acting as Executive Manager for the Strategic Information Unit. She's a public health specialist with over 18 years experience within the HIV/TB space, and certainly a leader in the context of these emerging pandemics. So we look forward to that discussion. The recording and the transcript of this call will be available on our website, africanalliance.org.za. Dr. Anban Pillay, thank you so much for your time and joining us, and we look forward to ongoing discussions and dialogues, in particular on how the Department of Health can support community organizations and movements in continuing to do this very critical but severely underfunded and supported work. So we look forward to engaging with you. Thank you for your solidarity and your leadership, and we look forward to the next few months.
Thank you very much, and please do share with us areas where you see weaknesses in the plan, etc., because the intention is to create access to the vaccine program, and I think areas where you identify those, please do alert us when you do pick them up. Thank you.
Absolutely.
Thank you, everybody.
Thank you, Dr. Pillay, and thank you everyone for joining us. See you next week, Thursday.